Great. So good morning, everyone. My name is Lee Fairclough, and this time I'll say my name. And I'm the Vice President of Quality Improvement at Health Quality Ontario. I'd like to welcome you to this session number 7, Strengthening the Quality Through Quality-Based Procedures. Before we get going, I just want to let everybody know because we know that there were transit problems and other problems this morning, and so some people missed portions of the plenary. A lot of people have been saying that they really enjoyed it, so we are actually going to try to get that posted on our website pretty quickly. And we will send out email to all attendees when it's available. So just wanted to make people aware of that. So we had about 300 people sign up for this session today, making it one of the most popular sessions this morning. I think this is really a testament to the commitment that we're making across the province to the success of quality-based procedures. HQO and our system partners, many of whom are on the stage here today, are actively working together and committed to supporting the field with QBP adoption. Today's session will provide a snapshot of some of the activity underway in that regard. Just did want to highlight quickly the objectives for this session, which are really, and I should just make sure I'm moving along here. First of all, the objectives for this section are really to provide you with a provincial overview of where we're headed on QBP adoption, share the results of some of the provincial survey conducted by the LHINs on QBP adoption, hear from a lead agency about their experiences in developing and supporting adoption of QBPs, and lastly, we'll hear from a clinician as to what this all looks like at the front line. In terms of the format for today's session, each panelist will have about 8 to 10 minutes to present. We're going to ask people to hold questions until the end, but we will make sure that we leave some space to do that. I should also just mention that we are going to need to end the session 10 minutes early. We've got another session coming in at 11:45 today. And so again, we'll make sure that we leave that space so that people can ask some questions. Before we begin, I did want to just cover a few disclosures. None of our presenters today that you see listed here have any relationships with commercial interests, received commercial support, and have no mitigating potential biases to declare. And this session, of course, did not receive any commercial support. So with that, I'm going to start off. Sorry, I'm just going to stop because I think we were going to do Melissa first. While they do that, I'm actually going to introduce Melissa Farrell, who's going to be our first speaker this morning. So starting off will be Melissa. Melissa was recently appointed the Assistant Deputy Minister, congratulations, of Health System Quality and Funding at the Ministry of Health and Long-Term Care, after serving as the Executive Director of that same division since January 2015. She leads a large area responsible for delivering on the government's funding and quality priorities. Prior to this role, she was the Director of Primary Healthcare in the Negotiations and Accountability Management Division. And as Director, she led a large team responsible for managing over 2,000 contracts with primary care providers. Melissa has held many other positions in government, including Director Implementation, Health System Accountability and Performance Division, where her key projects focus on reducing surgical diagnostic imaging wait times, reducing emergency room wait times, and providing patients with access to family care providers. So thank you very much, Melissa, and we'll turn it over to you.
That's great. That's great. Thank you so much, Lee. I really appreciate the introduction. So in some ways, I feel a little unworthy of sitting at this table, given the folks that we have sitting here. So I'm hoping that I can do this some justice by talking to you a little bit about where we have been focusing our attention in terms of the provincial approach to QBP implementation and adoption. I don't know if any of the team members are here. I'm hoping Sophie or Michelle or Michael. Yeah, okay, so we have a few folks that are here, which is great. So let me just start, as I always like to, with the action plan for healthcare and patients first. The session this morning, if you missed it, it really is worth, I think, looking online and having the opportunity to particularly pay attention to Danielle Martin's presentation, where she talked about spread and scale. And the truth is, this is all about spread and scale. So I really hope that we can dig into some of the concepts that she had been talking about today. So let me just start, as I mentioned, with the action plan for healthcare. We are truly committed to putting patients first. This is a challenge, as you can appreciate. On February 2nd, our minister announced patient first. It's our action plan 2.0. We like 2.0s too, by the way. 3.0 as well. 2.0 in terms of health links, but certainly on the action plan, it's a 2.0 too. The government promised, though, and this is really important because truthfully, it is changing how we are thinking about our work within the ministry and how we're delivering our work. Our promise is open, transparent, accountable, effectively managed government that provides value for tax dollars. That open and transparent part is so critical to our how we can be successful in terms of all the elements of the action plan. But that is different, I think, for us in terms of how we approach our business. So there are 4 priority areas which are worth highlighting, focusing. So we are focused on access, on connecting, informing, and protecting. And truthfully, in the quality and funding portfolio, which is my portfolio, we spend a lot of time on, of course, all 4 of these, but particularly around ensuring that our universal healthcare system is sustainable for generations to come, particularly when we're thinking about our funding models and approaches to funding moving forward. I could have showed you many slides about the trajectory in terms of our funding spend and how we're trying to bend the cost curve. I know people have seen that before. So actually, I'll skip along and show you that. No, I'm just kidding. But you've seen it before, and it is a real challenge, and it is a struggle for us, and it is something that we need to sort through. So as a result of that, though, 4 years ago, in fact, we're moving into year 5, we launched health system funding reform. People around this room will know that. And I just want to make sure that I'm touching on the fact that funding reform includes HBAM, but it also includes this commitment to quality-based procedures, where I think we've seen significant amount of work and significant success in trying to reduce variation that I'll talk about in a moment. The original commitment was for 40% of budgets to be HBAM'd through the health-based allocation model. So that's in hospitals. On the quality-based procedure side, there was a commitment, and that commitment has been clear, to 30% of hospital services would be QBP'd. So that's a lot. So where are we at? So there's team members here. I think we're currently at 12% with the current QBPs that we have. And think about, especially throughout this whole session today, the amount of work that has gone into trying to actually implement those particular QBPs. So if we're serious about that 30% end goal, which I'm willing to talk to people about. If we're serious about that 30% end goal, then what is it going to take for us to actually get there is a question, I'm asking myself, and I'd say we should be asking too. So we have here just the vision, the definition, and what we think some of the opportunities are in terms of QBPs. I'm going to skip through that. There are a few slides that I'll skip through, but the next one is around the evidence-based framework. So people often ask the question, how do you make a decision about which QBP you're going to focus on? Well, truthfully, this is the original evidence-based framework. This is the current framework that we're still using when thinking about QBPs. And if I had a laser pointer here, I would show you the real focus has been around reducing variation, which is in the bottom right-hand corner. Thanks, Fred. In the bottom right-hand corner. So is there variation in clinical outcomes across providers, regions, and populations? Is there a high degree of observed practice variation that is worth us focusing our attention on and trying to improve? So for a lot of the QBPs, that's really been the area of concentration and why we focus so much attention on those QBPs. The other point that I just want to make sure I'm clear with people about is we think about QBP, certainly internally, and I'm hoping you do too, in terms of a cycle. So there's the QBP selection process. So how do we make a decision about whether or not we should QBP something? Again, going back to that evidence-based framework. Then there's the QBP development process, which is really the handbook development. But then there's the implementation and adoption, which I'll point to here in a moment, some of the strategies and approaches we want to take on a go forward for that. And then there's the QBP maintenance. So they don't end as a result of the implementation and adoption. We have to continually be thinking about how the evidence is changing and how we're going to improve and think about QBPs programmatically. So there are some lessons learned that I think are really important. Probably there have been some surveys as well. There was a health system funding reform dialogue last year. What we have really been hearing on the QBP implementation front front is that it's fragmented and that people are looking for a consistent approach to how we're moving forward with implementation and adoption for the QBP. So I think we have heard that message, and the ministry have certainly heard that message. I know HQO has heard that, and so have all of the providers that are involved in this work. So as much as there's excellent, fantastic work that is going on, we know that there's more that we could do to create that standardized approach. So we did ask HQO, along with the OHA, and I know the LINs as well, we're really interested in engaging in a conversation about what does it take for us to really support QBP adoption and what can we focus on. And a team was pulled together, which might be hard to read, but a team was pulled together with all of the various provider groups that are helping, CCO, CCN, OSN, PCMCH, UHN, the OMA, to talk about what those strategies and approaches could look like. So this group, as I mentioned, led through HQO, and Suda Ckd is here, and Lee has been tremendously supportive of this too, and led by Lee, of course. There are some key principles that we have taken forward through the Advisory Committee for Health System Funding Reform to get endorsement of how we want to proceed with a QBP adoption committee and a QBP adoption approach. So we know that we need to have a core set of tools and supports for every QBP to assist with adoption. We know that each QBP should have a clear process at the outset to determine the adoption strategy. So some of them have amazing adoption strategies. CCOs are great. You're going to hear from Garth. They have an amazing team that works on this. Again, we're seeing that with OSN. There's many that are like that. Some of them, though, it's not the same. It seems inconsistent. We appreciate that. We also know that we need to have an evidence-based approach to how we're moving forward with QBP adoption, a common online location where you can access the tools and supports for QBPs. Adoption tools should be evaluated, of course. We should be celebrating our successes as much as we can, and we should make sure that there's a defined provincially and operationally, QBPs will be defined provincially and operationally on the outset. So those are the key principles that have been determined by that team, and I hope they resonate with people as we think this through. So then, as a result of that and looking at those particular principles, this team has come up with this as the core set of adoption tools and supports, which would be proposed with the vision that it would be the minimum core set, so there could be more, but you can appreciate measurement and reporting supports, change management supports, knowledge transfer tools, and improvement sciences. So really making sure that for every QBP, there's this framework that we're driving as we move QBPs forward. So moving forward with QBP implementation, we know that we need a suite of specialized practical programs and tools that will drive the implementation and adoption and accelerate adoption. And this is what all of this work is really about, and the reason why we're focusing on this in a consistent manner. So again, I go back to Danielle's points earlier today where she was really talking about those early implementers or the early adopters, and how the heck do we get from the early implementers and early adopters of change on QBPs out to really get everyone in the large majority, the late majority, slow implementers actually following the care pathways and actually implementing the QBP as we wanted. You're going to see some data from Kelly today too, some heat maps about implementation where there's still opportunity and work we know we need to do in order to move these ahead. So really want you to help us think about how we can continue to move this along. So where to next, I'll leave with you. We have our Health System Funding Reform Governance Committee, as I already mentioned, who is looking at adoption and asked us to bring this consistent plan forward. We have our committee that is trying to create that consistency across, and then developing the regional strategies, which Kelly is actually about to talk about from the LIN perspective. So I think I'm a minute over, but I was trying.
Thank you.
Thanks.
Thank you. Thank you so much, Melissa. It's a great grounding on kind of where we are provincially. It's really my pleasure now to introduce our next speaker, which is Kelly Gillis, and a good colleague and somebody I enjoy working with very much. Kelly will be speaking of how the vision of QBP adoption is being realized at the regional level. Kelly is the Senior Director of System Design and Integration at the Southwest LHIN, which she joined in 2006. She spent the majority of her career in leadership roles focused on healthcare strategic planning and system integration within southwestern Ontario. Prior to her role with the LHIN, Kelly worked for London's hospitals as Director of Medical Affairs. She was also a system integration leader for the Huron Perth Hospitals Partnership and worked as a senior planner with the Huron, Perth, and Thames Valley District Health Councils. Please welcome Kelly.
Thanks, Lee. So there's a big theme in my career history that most of the organizations I worked for don't exist any longer. So I'm just saying there's been that pattern in my integration work over the years. So I'm really pleased to speak to you today, and what I'm bringing forward is a couple of things. A bit of an overview on some of the work that has been done across the 14 LHINs around the implementation assessment survey for QBPs that's already been referenced. So I want to give folks a glimpse of some of that information, and really it has been information that has already been well used by the adoption committee that Melissa was talking about in starting to look at those principles and tools that we need in the province to support a more systems approach to QBP adoption. And I also want to give you a little bit of an example of some work that we've done in our LHIN in the Southwest, looking at stroke in particular, from a systems approach and a system redesign approach. So this is what's been now fondly referred to as the heat maps that are being developed as a result of the QBP assessment survey that was done across the province. And the Southwest LHIN actually initiated a survey in our LHIN, and with the encouragement of Lee and HQO, working with partner LHINs across the province, the survey was actually undertaken with all hospitals. And pleased to say, I think we had about an 86% response rate of the hospitals that were expected to respond to the survey. And in some LHINs, we had 100% response rate. So it's really given us a good sense of where we're at with implementation of QBPs. This heat map is looking at the 14-15 QBPs, and I won't go into the details of how you read the map. Suffice to say, green is further along and into sustainability. Red is at the early stages of adoption. And you can see for our 14-15 QBPs, there's been quite a bit of progress across the province. We have each of the LHINs listed down the left and the QBPs across the top. This slide, however, is the 15-16 QBPs. So you can see we're much further behind, as expected, with the adoption of those QBPs within and across all of the LHINs. And at the bottom, we actually break the information out summarized for HSFR hospitals and non-HSFR hospitals. So that information is there as well. And you can see that the non-HSFR hospitals overall are slightly behind the HSFR hospitals. But again, the pattern is pretty consistent across the province in terms of where we're at with adoption. The survey also looked at some of the barriers to implementation of the QBPs, as well as what individuals thought would help enable adoption across the province. And I apologize because I think the slides didn't appreciate the widescreen version so much in the conversion, so it's some pretty small print. But really there was a big theme around the need for resources to support adoption, challenges that hospitals were experiencing around volume management, and the need for clarity of direct or indirect cost inclusions related to the financial component. And then some of the enablers that were talked about by the organizations, looking for clarification of indicators and costing information, the opportunity to support information exchange or best practice. So we know lots of good work is happening within LHINs and across the province. How do we share that information in a timely and effective way? Looking at need for additional education and workshops, as well as the opportunity for organization-led expert education sessions to support adoption. So these were some of the strategies that were talked about, and again influenced some of the discussion with the adoption committee that led to the principles and the tools that Melissa shared. And this is another slide that comes out of the survey, also particularly interesting from my perspective. It's looking at regional initiatives to support QBP adoption. So again, we have QBPs listed around the left and the extent of regional activity related to those QBPs. And I'm just going to highlight the bottom one, which is stroke, which you can see across the province. There's been a lot of regional activity related to stroke QBP adoption. And certainly we see where there are provincial organizations, Stroke Network in this case, we know that they play an important role in supporting adoption for the QBPs that they're related to. So in our LIN, again, apologies for the slides, we really set out to look at adoption of the stroke QBPs, but at the same time we were looking at system realignment. So we knew that we, again, looking at our data, had some of the worst outcomes in the province for stroke, and we wanted to look at how we strengthen our district stroke centres to be the point of care for individuals experiencing a stroke in the Southwest LIN. So looking at our data, again, really created that compelling case for change. We had a high risk of 30-day mortality in our LIN. We know that the best practice information talks about the need for a critical mass of at least 165 ischemic strokes per year within each organization. And in a LIN where we have 28 hospital sites providing acute stroke care, we know that we are not achieving critical mass. And this slide particularly highlights that. So you can see the line that identifies the 165 as the number of reaching critical mass. And only one of our sites was actually servicing that many volumes in the course of a fiscal year. And then we had many sites that were providing care to much fewer numbers of individuals. And so I think the compelling message here is the case for change and the commitment that can be garnered when you have data that really paints a picture and outcomes that are showing that you're not achieving the best care. We also, as part of the IDEAS project, we had a team that actually started out the work around this project going through the IDEAS cohort. They were one of the early cohorts, and they did a survey looking at some of the best practice components across all of our sites. Our district stroke center sites are to the left, and then all of our other sites are to the right. And you can see there's a lot of red and yellow, particularly to the sites to the right, where best practices were not being followed. And again, just referencing back to Danielle's comments this morning, that notion about where you get care really impacts the quality of that care, and this certainly is a picture that demonstrates that in terms of how care was and continues to be delivered in the Southwest. And we have made a number of strides forward, but we have a way to go to get to quality-based stroke care within the Southwest consistently for all residents. So in the end, really in a very, probably one of the most easiest planning processes to get to consensus that I've been a part of. There was agreement and commitment from all of the hospitals in principle to move to centralization of stroke care at our district stroke center sites. And so there was a recommendation and support for moving from 28 sites providing stroke care down to 7 across the Southwest LIN. So truly a transformational change that's been envisioned for the Southwest LIN. Some of the challenges and the successes around moving this forward. So it's a story that's still in its creation. So we have a recommendation on the table. We have strong commitment from providers. One of the key lessons learned, and probably no surprise to people in this room, the devil's always in the details. And at the end of the day, the biggest challenge for us is making this system transformation work in a cost-neutral environment. And in fact, we can't make this work today in a cost-neutral environment. So looking at how we find the resources to implement this so we are able to provide that quality-based care consistently across our LIN is one of the key challenges. Some of the enablers for success, though, using our data to demonstrate our opportunities for improvement, creating a set of champions that are willing to move this work forward and be committed because there is a compelling case for change. Keeping our eye on best practices. So one of the things that happened, of course, with the QBPs being updated on a regular basis, some of the emerging best practice information around the clot removal surgery, which is under review, came into the forefront of discussions. And are we actually now designing a system for current best practice, or are we actually looking into the future and ensuring that we're designing a system for future? So that balance of what our best practice is telling us today and where we're headed in the future becomes really important in our implementation and planning work. And how we think about that from a cost impact perspective as well has certainly become part of the conversation moving forward. So I think that's what I really wanted to share. I think the parting comments that I would leave, there's been some great leadership across the LINs working together. Certainly there was leadership from our LIN, and my colleague Mark Britnell's in the room, and Nicole Robinson really led the work around the Pan-LIN survey. That information is now available in each LIN by organization. So those of you in the room, if you haven't seen that information in your own LIN, it's recently been rolled up. The information is now out there. It helps us to understand where we're each at and also how we can work better together from a systems approach in the province. So thank you.
Great. Thanks very much, Kelly, and really an inspiring example at the regional level. Our next panelist is Garth Matheson, who's going to bring the perspective of an agency that's facilitating adoption of QBPs across the province. Garth is the Vice President of Planning and Regional Programs at Cancer Care Ontario, where he provides strategic leadership in the development and implementation of the Ontario Cancer Plan, as well as operational stewardship and oversight of Cancer Care Ontario's 13 regional cancer programs. Garth is responsible for performance management of Ontario's cancer system priorities, capital planning, and for cancer and renal components of the health system's funding reform. That's why you're here today. Previously, Garth held senior leadership roles at the Royal Vic Hospital in Barrie, the Royal Victoria Regional Health Centre in Barrie, Sunnybrook, and as well even worked in other parts of Canada, in Manitoba and Saskatchewan. So I think has lots of perspectives to bring. Welcome, Garth.
Thanks, Lee. I should have given you the Twitter bio instead. It would be much shorter. Kelly, I'm reminded with your scorecard, right? Like, I don't know the rest of you guys, but you do these organizational things. You try to make your organizations as great as they are, and then you put out a satisfaction survey to your staff, and it's like, meh, right? And it's like, what more can we do to get everybody riled up and know what's going on and everything else? And it's just like these scorecards. We do a ton of stuff, but yet, there's the adoption is red across the board in some cases. So what is it going to take, right? So it's very difficult to get this right. I got too many slides, so I'm going to go fast. Sorry about that, guys. So CCO is the only agency actually that has sort of legislative right to flow dough, right? So we're a little bit different than some of the others. So we can actually take it from a design, build, operate, and maintain, right? So we can use the same group that designs the thing as the same group that's actually going to performance manage the thing. And we can take it all the way through and really, really leverage the funding envelope in terms of how do we sort of change the quality metrics of what we're trying to do. So it's a little bit different, and we've got that privilege, and we certainly use it to our advantage. Just a brief, here's the QBPs that we have, and of course moving forward we want to do a few more. A couple of big ones for us is just to continue extending the cancer surgery one, and also we got to get into radiation treatment. If you think of the three-legged stool, we got chemo, we're into cancer surgery, we got to do RADs as well, and that's so we can sort of get the front end of a patient that presents and not have to triplicate that. We can do that once and sort of make it flow into the different streams from there. So that's kind of our thought process. So what does it take to actually pull this stuff off? There's kind of a list, and I've got a lot of slides. You can look at these later, but I'll kind of go through a few of these things as we move through, and some of it might be a little bit of a duplication. But you got to have a problem to solve, and although it's all about changing quality, which is why we're in the game here, it's not really about funding. Just to give you a sense, and I should have had another slide here, but this is Ckd Funding, and Ckd was a provincial priority program, so it was actually funded specifically with a protected envelope to it, and these are the hospitals that got the funding from the ministry for that priority program. You can see it was a bit of a squeaky wheel syndrome back there where the hospitals all got funded differently, and there is absolutely zero correlation to quality at all. Right? So it's trying to even get to a level playing field, and we know in cancer where we have kind of a level playing field, we still get variation in quality too as well. So it's really hard to sort of line this up so one thing sort of reacts to the other, and what's the correlation and causation of some of these things. In systemic, we had a problem that we had per case funding. It was a bundled envelope, but it was like an average price, and you get paid the same whether you treated a patient or not. No perverse incentives to actually treat them. Paid them whether you treated them or not, but it was a lifetime payment. You only got paid once for that patient. If they came back next year and the year after and the year after, the hospital didn't get any money. It doesn't really work for a fiscal environment. So it was really just a proxy for growth. And it actually happened very, very well for us to keep up with access and growth, but it wasn't very good for a quality specific sort of leverage. Got to have a plan. I think Melissa put it out there. We need a plan, and we've got lots of shiny brochures with our plans. So, we know what we want to do. We know what we want to achieve, and that sort of grounds us in terms of what we want to do and where we want to leverage the dough to make it happen. And you need some accountability and governance frameworks. Who's in charge in the region for this thing? Who's making the decisions? What are the committees that are going to actually implement this stuff and own it? And what's the choke point to make this happen? So, our formula is always to have sort of an administrative stream and a clinical stream, bring those together and have them flow up through the different chains of command to make sure that we all know who do we call when something's going wrong. And we always try to look from an integrated perspective of having all the parts of the clinical elements that come together. So if we have a QBP in systemic, we still need to talk to the radiation people, the surgical people, the pathology people, the imaging people, exactly. And so we want to make sure that that comes together. Now, for us, we have clinical leads in every one of those elements in that box in the middle. So we have regional leads for systemic, for RADs, for pathology, for primary care, for palliative care, et cetera. These are paid physician leads across the province. I think we pay about 13 million for physician leadership to help us get this done. Got to have a choke point in terms of a leader who's in charge, and this just happens to be a regional vice president for cancer, but we also have regional directors for Ckd. It all flows through to them, and these are the people that we contact when we have issues. Just an example of the GI endoscopy governance model. Pretty standard sort of PMO stuff, right? You got to have the sponsor groups, the ESGs, and you got to have the sort of advisory groups, the scientific people, the clinical people, the administrative people coming together to make this happen. Lots of panels and things. And if we figure out what sort of the element that's probably the magic to the soup is, making sure the physicians are engaged from start to finish. And we try to use the same doctors for the design, build, operate, and maintain. And I think that's helpful because you got a bunch of docs who design it and then a bunch of different guys who are maintaining it or doing the performance on it. They're all second guessing each other in some ways. It also helps with this concept of developing a best practice price. Well, best practice for the designer is kind of a blank check. Best practice for the implementer isn't a blind check. So you've got the guys that got to make it happen. They got to pull it off, and getting them from sort of the front, or left to right or front to back sort of view of this whole thing helps us move that forward and get a lot of credibility if you let them help you with that. Just some example again, 70 people involved in the endo one. We actually even go to the OAG to get their advice and make sure that everybody's involved. Another look at that is just that we use different tools for that, face-to-face meetings, one-on-one, webinars, teleconferences, whatever it takes to kind of get everybody engaged with that, sometimes with docs, sometimes with decision support, sometimes with finance people. What's this one? Systemic treatment, 300 people helping us figure out what are the regimens that we need, that we will have in our model, that are approved ways to treat people. Because remember, in our system for the QBP for systemic, if you don't treat them according to guideline, we don't pay the hospital. So it's very much got a cap on it. Do it this way or you don't get paid. And of course, there's 100 different diseases in cancer. So, there's 1,500 regimens we had to figure out. And then the other tools that we have, I can't go through them all. Certainly Irene Blay, who is director of our funding unit, could go through it with any of the people that want to sort of do this. But, there's kind of the list of all the stuff that Melissa was throwing up in terms of what should we have for all QBPs. And we have these all at CCO for sure. Just a snapshot of some of those tools, just the technical specifications, of course the clinical guidelines, but also the comparative reports that we use for benchmarking and stuff. All this stuff shows up in Systemic here. Anyway, you can see our website, so the users can go in, click on their reports. How am I doing? How am I doing versus someone else in terms of how they're doing? Where am I spending, or how am I treating patients that are not according to guidelines, so I'm not getting paid for that, et cetera. So they can go see all these reports on access through our website. Also, it can show you, there's a sort of that blue and red gives you a sense of how am I doing against the rest of the province kind of stuff. Just to give you a snapshot of the benchmarking. That top right graph there just shows you, what is your percentage of the regimens that you've been using in the different bands that we have. So people can go and get this stuff, access it at any time. Also have a public one, so anybody can go and see, well, what regimens, what are we paying for, and also a place for people to say, have you thought about this one, right? So maybe you went to a conference or read something, or there's a new something came out across the planet somewhere. You can feed that into us and we'll work that out for you. Just a little evidence here. So we moved the needle on just this one is in terms of people getting treated according to guideline from 92% to 97%. Seems like only 5 points, but when you get to those points, as you guys know, those last few are very, very hard. So this is actual proof that funding for quality only will change. And of course, this is all about behavior modification, right? This is what we're trying to do, is just change behavior. Got to have the contracts in place. We have a full contract shop. We give out hundreds of contracts, and they have all the schedules for what is required for your quality and your data back to us, so we can make sure this data thing works. Got to have the IT, IM backbone, and CCO does have a big informatics shop, as everybody knows. So the data coming in is, I think we have access to more data points almost than the ministry has. Like, we seem to have partnerships with everybody to get data from everybody. So it all comes together very strong for us to do the cross-reference. My time is up. Got some tools there. Remember Dr. Hudson, you either motivate people by paying them or embarrass them. So we just, we throw up the comparative scorecards and make sure if you're red, everybody knows about it. And if you're ranked number 14 out of 14, everybody knows about it. And it sort of gets that competitive edge going. We meet with you quarterly, not just to chase your tail, but also to find out how can we help, right? What is the barriers and how can we help through those? What are you experiencing? More reporting, but you got to have the stuff. Got to have the people, the place, the things, the tools, the drugs, etc., to make that all work. And we're doing an evaluation. We've come up with a framework of the evaluation for all our QBPs, so we'll be rolling that out with Ckd over the next few months. And that's it. If you want to chat with me or Irene at any time, certainly on the slide deck, you can approach us and just give us a call. Thank you.
Great. Thanks very much, Garth. Our final speaker is Dr. Alan Forster. He's going to help tie all this together and actually bring the perspective from the front line. Alan really brings us somebody who is on the ground, specifically at the Ottawa Hospital, planning for and implementing QBPs. I'm going to say a couple more things, but not quite as long as the others. So Dr. Forster is a general internist. He's the Chief Quality and Performance Officer at the Ottawa Hospital and Vice Chair of Quality and Clinical Services in the Department of Medicine, Faculty of Medicine at the University of Ottawa. He's a professor there. He's got 135 publications, and he's won several awards acknowledging him as a leading scientist. So it's really our pleasure to have Alan with us today.
Thanks for having me, and thanks to the other panel members for the great presentations. I'm going to talk to you about this, our program at the Ottawa Hospital. Hopefully give you some of our lessons learned and some of the things that you can do differently that we didn't know when we started. Really, I think just to sort of take-home message is really this is a great method to engage clinicians and staff in the efforts to improve the value of healthcare, improve quality, and reduce costs. And I think that's really the main message for us who practice quality, is that this is a tool that you can use to get people to the table in a way that really I've not seen in any previous efforts to get people to the table. And I think that's really one of the things that you need to think about. For us, really the way we've tackled this is we've made this a clinical quality initiative, and really it is about improving the value of healthcare, the improving quality and decreasing costs. And when we're moving this forward with our teams, what we strive always to do is be best in province, both on the quality side and the cost side. And so we use benchmarks a lot. We have access to information to guide our teams. And really, that's really where we're striving. And our thought process is on both the quality and the cost side is the yardsticks will be moving every year. So if we're not striving to be the best, using data that, granted is usually often a year or two behind, if we're not continually striving to improve, we will drift behind where we want to be. Another big part of our approach, and really at the heart of it, is the leadership for the quality-based procedure. So what we've done is we've identified at the top level, clearly the CEO and chief of staff are responsible, but as you move down the organization, there's a supporting infrastructure that I co-lead with our chief financial officer. And we're managing the supporting infrastructure, which involves a multidisciplinary team from quality, from our financial group, from our performance group. And now actually recently added from our information systems group, so that we have a core working team that provides support to the clinical teams. That support team is really supporting an infrastructure that is run through the clinical operations. And so really they're ultimately responsible. And again, we have a dyad structure there where we have a physician lead and an operations lead who are jointly responsible for achieving the objectives that get set out. And actually that dyad, that relationship, I find, again, that's another benefit of the program, is bringing that co-leadership together and help asking them to be responsible for achieving objectives, has really strengthened our organization by just having the physician and nursing leader or other leader work together. Clearly data is a fundamental piece of this, and we've been lucky to have benefited from some investments along the way. Just as a measure of our success, here's a report. This is and I'm not going to ask you can't go through that. I'll just say that this is a list of our QBPs at the start of 2014-15, and we've projected out what our actual costs were in the preceding year, what the price was going to be for that year, and the expected volumes. And you can see the variance per case, which is the red column there, shows that at the beginning of the 14-15 year, we were going to be losing money across all of the QBPs. And I'll just tell you that was about a $4 million hit for our organization. And that I'll tell you, was a motivating factor. So, the case for change was clearly there. And that really helped bring people to the table. It is really important to have good data to understand variation. As was mentioned by Melissa, variation is really the key to this and reducing variation. On this graph, you can see a frequency distribution by length of stay and by cost buckets. And you can see that they actually marry each other quite closely. And you'll see, this is for pneumonia, for the QBP for pneumonia. You can also see that there is an interesting pattern to the variation, that you have a central group with a reasonably short length of stay, and then there's a long tail. And actually, when we look at that carefully and across all of the QBPs, we're seeing that there is a tail to that distribution where small groups of patients are disproportionately costing our institutions. And that coupled with the following slide, which shows where we've taken OCCI data and including our own, and compared our spending within various spending buckets to other hospitals in the province, both other teaching hospitals but other peer hospitals, we could quickly target where we saw the challenges. And you can see, the blue bars representing our spend versus the red being the peer hospitals and the green being all in province. You can quickly see, and clinicians can quickly see, where we're spending either more or less than provincial peers or provincial hospitals in general. And so again, this is coupled with the idea that that prior graph that shows that the distribution is skewed, that there are small groups of patients, and with the fact that, really when we look at our spending within lab and medical imaging and pharmacy are not out of line, that then helps our clinicians then work very effectively towards the objective that needs to be met. So in other QBPs, we've seen spending out of line in lab, for example, or in pharmacy. And again, that's where we drill down with those clinicians at the table. And I'm happy to say that through a process that I've described, we were able to get, you can still see some red, but the red numbers are much smaller than they were at the beginning, and the green numbers are there's more green numbers. And we turned the minus $4 million deficit into a small surplus based on the QBP. So we were quite happy with that. The other thing that happened, and I don't have the data for this, but just to say that our wait times remained constant, our patient experience scores actually improved, our hospital standardized mortality ratio improved, our complication rates improved. So overall, and our readmission rate stayed stable throughout. So despite the fact that we were able to take out, a projected deficit to a surplus while maintaining quality, I think is testament to the approach taken. We did an external review. We actually paid for someone to come in and help us say what did you do well. We were able to find cost drivers that were helpful. We did get the engagement we wanted. There was some challenges in managing improvements, challenges when issues, particularly when they resided outside of our organization. And there was also a kind of feeling that although we had reached the top level, the middle manager level of the organization, there was a need to actually get right down to the frontline staff. And it was felt that if we enhanced our efforts to put the quality in QBP, that would make an improvement. So in order to do that, what we've tried to do is take a higher level view. Rather than focus on specific diagnoses or procedures, we're trying to think of things as a service line and think more holistically from the start to finish. And we think that is a better way to engage frontline staff and a better way to view the challenges patients face along the continuum. We're also adopting a process improvement approach to address the care along the continuum, and making sure that the staff who participate in that service line have an input into the opportunities for identifying improvement opportunities. Finally, it's not just about identifying the opportunities. There is managing the system. And what we're trying to do is shift our culture within our organization to one that's more aligned with our vision, which is to provide excellent care, to provide high quality care for every patient. And to do that, we need some other tools. So we're investing in the just culture and also investing in creating more quality improvement capacity within the workforce. Finally, and this is actually a really important one for us in our region, I suspect it is for all of you, is that the need to engage partners outside of our institution is critical. Many of the factors, you saw that long tail, a lot of that is caused by challenges outside of our organization that we need to work with partners to make sure there's adequate capacity across the continuum. And I'd be happy to take questions afterwards. Thank you.
Thank you so much, Alan, and thanks as well for sharing the findings of your external review and sort of how you're thinking about responding to it. That's really great. So hopefully we've provided a bit of a sweep. We've got people jumping up to the mics. This is terrific. So we've got about 20 minutes. Thanks, everybody, for in your time, and we'll open up the floor.
Super, thank you.
Can you just introduce yourself, too?
Sure.
Yeah.
Sam Marie from Trillium Health Partners.
Great.
Several of the QBPs have very high readmission rates, but patients are often readmitted for a different diagnosis. So a COPD patient is often readmitted for CHF or pneumonia. Ironically, this may potentially lead to more funding dollars for hospitals. Is there data to support that QBPs are improving the health of patients beyond the original diagnosis?
Okay, great. Anybody would like to respond to that? Alan, go ahead.
Is the mic on, or?
I think so. Are the mics on?
I mean, I think the short answer is no, there is no evidence at this time in Ontario. There has been systematic reviews addressing this issue, like the effect of activity-based funding models. And I think the jury is more or less still out on this issue. There has not been negative impacts on quality. There has been some suggestion that there is benefit, but it's not, I would say, a step proven. And yet there is a strong improvement in cost. So I think that on the balance of it, it probably is a good thing. But from what I know, there's no proof, and there's no proof in Ontario of improvement in clinical outcomes.
Well, I think one of the difficulty things that we've done is we've chosen the chronic diseases, right? So, but when we started this, what was it? I guess 3 some years ago now, it was quality-based, procedure. So it was just the, this episode thing in the hospital, ta-da, and let's fund that better, and get that part right. And as we're moving towards quality-based programs, we're kind of extending it out. I think there's been lots of discussion, but trying to connect the dots of these sort of comorbid conditions and things like that is very, very difficult. Certainly, almost every cancer patient has something else too as well. So we struggle with this issue too as well. But the metric for are you a healthier person now after that, I don't know how we'll sort of get to that, but it's it's a great debatable question for us to try to figure out for sure. And whether that's more bundled approaches or something, it's just hard to figure that out the way you could fund these things, but does the health system isn't lined up like that, and the data isn't lined up like that. So it would take some fairly fundamental changes for us to sort of look at it from that picture, although other jurisdictions are trying, and we need to learn from them for sure.
Do you have a comment?
Really, I would probably just repeat a lot of what the other two presenters have said. Certainly, I don't think that we have the data today in Ontario, but we are evaluating health system funding reform. CCO is evaluating their QBPs, so hopefully we'll be able to garner from some of that, whether or not we're achieving the outcomes that we really want. But I think this is also why we are spending a lot of time thinking about bundled payments and how to change, thinking about quality-based programs versus quality-based procedures, all the same things that I think Garth was pointing at. this is driving us, I think, to think differently about these, because we do want to be driving outcomes, and we do want to see the improved patient care as a result of this, and we're looking for that success.
I'll just make one final comment. I think as we've been working with the adoption committee, we've been looking at the survey results about how we're doing in terms of introducing. And that's actually the views of those organizations and how they're doing in implementing. We've had a lot of discussion, looking at Thomas Custer's, a lot of discussion about the data and how we can actually now look at the data to see the kind of change that we may be seeing. And I think with that, part of the goal here would be that we would make it more predictable what organizations might expect to get and be able to see in terms of where there is variation, where we are seeing some shifts and some of those important quality outcomes. So we're a ways off, but I think that there's a real commitment and recognition that we've got to really turn our attention to how we could look at some of that data. Matt Morgan, who holds a similar role to Alan at Mount Sinai Hospital, came and spoke with our committee as well. And I think one of the messages he had, and I'd be interested in your thoughts, was that there's hospitals that have access to the kind of data that you showed us today, and there's others that maybe don't. And how can we actually start to use that data differently as a starting point to then be able to say what's the change we can make?
Yeah.
Are there other questions or comments from the floor? Tom is coming to the mic. Get ready. It's going to be a tricky one.
Uh-oh.
I'm Tom Clausen, and I'm on the Board of Health Quality Ontario, so I guess I have a conflict of interest. First of all, I think it's terrific that you're able to focus on reducing variation in terms of the individual items that are funded through the quality-based procedures, and hopefully we can align quality performance indicators to really understand whether that is in fact improving quality. I mean, I'm talking about across the system, not just locally, which I gather you're doing, and you can correct me if I say anything where I'm wrong. But I was wondering, the way it's been described, whether we're actually creating an incentive for hospitals to admit patients. Because I'm leaving cancer aside, where I know hospitals are funded to do a certain number of, and of course cancer, you either, I suppose, have it or you don't have it, but there's a lot of other things here where it's a decision to admit that is made. And if you know you're going to be funded through QBP because you've admitted a patient and now you just have to deal with them in that context, whether we're actually providing an incentive to admit. Is there anything in this that looks at variation in terms of number of procedures? I'll use, for example, hysterectomies, which I don't think is a QBP at the moment.
Not yet.
Not yet. But if it was, in North Bay, if you're a woman, you have what, I don't know, 4 times as much likelihood of having a hysterectomy as you do in Newmarket or in the Central Lynn. So there's no particular logic to that. So if you fund on the basis of the number of procedures that are done and how they're handled from a quality protocol perspective, you have to ask yourself the question, you have to go farther back in the process to understand whether the hysterectomy should have been done in the first place. I'm told, I won't name the hospital because I might be wrong in selecting it, that in one of the hospitals, the C-section rate is 50%. So if we are including obstetrics, are we going to fund C-sections on the basis of what they are, or what we think maybe would be a more reasonable norm? And when we get into QBPs, it just seems to me that reducing variation in volumes, not just variation in how you deal with the individual patients once you've got them admitted or having a particular procedure, makes a lot of sense. Hope you're not going to tell me that you're already dealing with this and I've just wasted 5 minutes of your time.
Do you want to start, Melissa?
So I would say, so obviously that's a very good question, I think. There's a couple points that I think are really important. So one of them is, this is coming up a lot with some of the new QBPs that are in development. So I don't know if people are aware, I'm starting to hear that people aren't, but there's 14 QBPs that are currently in development. I don't think they're going to get implemented next fiscal necessarily, all 14, but you can appreciate there's a lot of clinical handbooks and this work that's being done related to a lot of QBPs at the moment. A couple of them where this challenge, Tom, is coming up a lot, hysterectomy, and the other one that's currently in development is low risk. It was originally C-section and is now low risk delivery. And truthfully, when you get together as a clinical team and you're starting to talk about this, it doesn't make sense as a C-section. We don't want to increase the number of C-sections. We want to decrease the number of C-sections. We want to reduce that variation. And we're talking about a pathway that goes beyond the pathways that we've traditionally been thinking about. So I think this, to me, goes back to the point Garth was trying to make earlier, which is where we are saying it starts and stops is probably broader than we're currently focusing, and we need to be shifting QBPs to more programmatic QBPs than to this procedure base. And there's work that needs to be done to help support that.
And going upstream
Yep,
rather than
upstream,
just
exactly.
focusing on
Yeah.
downstream.
And I
which-
think, exactly. Yep.
Okay.
That's great.
Do you want
Thanks.
I think it was a great question, Tom, and actually, CCO and HQ are working together on the hysterectomy one for sure. And the problem is, these tables get together and it's all about how can we fund this better and everything else. But the key is how do we get better quality out of this and how do we use the funding to sort of drive that. We do have the issue, not in cancer surgery where, there's usually a tumor if somebody does the surgery, let's hope, but in screening. Colonoscopies, right? So there's, probably 20% colonoscopies don't need to be done. But it's a major component of the practice plan for the physicians, and particularly in small areas. So one of the things I think we need to move towards is how do you use the physician remuneration with the other parts of the remuneration and sort of bundle those together so the physicians don't feel threatened financially by actually changing quality in the system, right? So to make sure that part is protected somehow. And I think, if we can stumble across that bridge a little bit in a couple of good pilots, we might be farther ahead.
Thank you.
Alan, did you want to say?
I have a couple of points about variation. I think the variation is really important to study and understand, and oftentimes the variation will reflect some unmet need by the patient. So you saw that variation. It was quite a skewed distribution for length of stay and cost for COPD patients. Well, when we look within that, those are different patient populations, and our care model is the same for all of those patients. And so the idea is that maybe we need to think about the patients with COPD differently, depending on the variation in spending or in duration that they need to spend in hospital, rather than treating them all the same. And I think that just by having that framework, the clinical team working with operations to sit through and solve those problems is one way to address it. But it has to be done. It can be done at a hospital level. It can be done at a service level. It can be done at a regional level. It can be done at a provincial level. But I think that variation is really important to understand from just asking yourself, are we meeting the patient's needs? The other piece, just to comment on about the sort of incentive to admit, that is absolutely present to a point. And in fact, it's the incentive to admit low-risk patients. It's not just admit, it's admit low-risk patients. And so I do think that as we move through the journey of this, there has to be, in order to assure equity and standards of performance, there will have to be some serious thought to developing standard admission criteria, for procedures, standard indications for the procedures, all of which will be good things for patients in Ontario and good things for our institutions.
Just
Right.
wanted to mention that ISIS has done work on PCI and cabbage and identified that 50% of the variation is due to the operator. So it's due to the doctors that are working. It has nothing to do with the patients and the patient condition. So you could, ISIS is a good resource, could look at a number of other things of the variation that we're seeing in propensity to admit. And I must say, Kelly, that presentation or that set of slides you showed on stroke is just overwhelming in terms of, gosh, I got to be careful which hospital I go to if I have a stroke. I used to be the CEO of the Ontario Hospital Association, but it's just overwhelming when you look at how it is today. And so it's not even whether you get admitted, it's where you go to get admitted as well. Okay, thank you.
Thanks, Tom.
Lee, can I just add a
Yeah,
couple
please.
of comments
Go
too?
for it.
I think from a Lynn regional planning perspective, and the challenge with the volume of QBPs is actually being able to take a regional approach to all of the planning, but where we've been able to focus with partners to look at capacity requirements into the future and have that guide volume allocations into the future. There's more opportunity around that. I think that yet needs to be advanced within and across LINs. And the other piece I just wanted to add, the next step for the assessment survey is to, for selected QBPs, overlay some of the scorecard information with the QBP assessment to see, are we actually seeing the outcomes being achieved in the areas where we're seeing hospitals self-reporting greater advancement in terms of implementing the QBP. So I think that data will be really interesting to start to bring the outcome information together with the self-report from the hospitals around the assessment and implementation progress.
That's great. Thanks. Did you have a final, or can we go to Burnham?
question.
Another question.
Thanks. Zanita Hergy, having worked with a number of hospitals across the province on implementing QBP structures and monitoring frameworks, I think one of the key issues that keeps coming up is the lack of case costing data in those facilities that aren't case costing hospitals. When I go back to the comments that were made by Staney this morning, it used to be, we talk about cost and we talk about quality, but in reality, if you're a case costing hospital, the first resource you're going to go to is your case costing data to see how do you compare in your departmental costs in comparison to other case costing hospitals. And maybe that's a clue to variations in best practice or where your quality should be. And having worked with a number of hospitals, some of which don't have the capacity either to implement or have case costing available to them, I think that's going to be a huge struggle going forward, given the number of QBPs you're planning on moving forward with in the next near term. Is there any thought to developing either tools that could proxy a case costing environment for those hospitals that don't have access to case costing? Are you planning on perhaps expanding the number of sites that are going to be potentially case costing facilities? I know you've tried that in the recent past. I'd be interested in hearing some of your success or thoughts going forward.
Sure. No, thanks for asking that question. And it's interesting. I was going to actually talk about case costing earlier because I know my predecessor, one of them anyway, Don Young, used to, in every presentation, talk about please sign up to be a case costing site because it will be one of the most important things you do as an organization if you want to be successful under health system funding reform. And it's not just from a QBP perspective, but it's also pretty important to understand your case costing for HBAM as well. So I'm glad you raised the question because it's so fundamental. There is a strategy. There is a plan. There's actually a plan to roll out case costing to a number of hospitals, and I don't have the numbers with me, and I don't know if Fred has it either. There are hospitals saying no, thank you, and sites that are actually turning away from becoming case costing, even though we're paying for the licenses and we're doing significant work with them. So, we are taking that back to say, so what does this mean exactly? Because when we started with case costing, everyone wanted, there was people clamoring in order to get on to be part of that group. And we have a number of them, don't get me wrong, but there's waves and phasing that we're working through. And we really do need to, everyone should be a case costing site. And we should be working and striving in order to get ourselves there. So don't, yes, there's certainly an implementation strategy. There's waves, and the focus is to actually get more sites, and we're doubling the number of sites in the next 3 years. But it is concerning to me that there are sites that are turning away, and I have heard it's because of the resourcing it takes internally in order to be successful.
I think it's the resources, but it's also, I guess, the inability to attract additional resources, because the same people that are doing the decision support work on, QBPs in non-casting sites would be the same ones that they would then have to divert to implement case costing. And just the knowledge transfer and capacity and resource availability just isn't there. So we may need to think about different models, right?
Yes, and we have been talking about what are the tools and supports that we can provide to those sites that aren't case costing sites. And in fact, that's been a topic of conversation at the adoption table. So what can we provide in terms of predictor tools and other things that we can be doing for those sites? And then I guess the other thing that I just want to make sure that we plug is the scorecard work that Thomas has been leading to create some benchmarking and scorecards that you can look at for your QBPs that go outside of that. But I don't disagree that case costing is really important.
That's great. I know Alan wants to make a comment, and I wonder if when you do, can you also comment on the importance not just of the financial data?
Sure.
Can you?
Yeah, so I'll just say that the case costing is actually fundamental to running your hospital. I don't know how you can look after populations if you can't figure out what you're spending on individuals. It is challenging, and that is for QBPs, but for the whole operation, I would say. I understand there is some reluctance to implement because of the opportunity cost to making it happen. There also is some, I would say, oftentimes I'll talk to CFOs and other people who have to pay for implementing it. And their approach for accounting is maybe not necessarily, they can probably do without the case costing. But it's when you turn that into the operational realm to say, okay, where are we going to make opportunities? It becomes really challenging for the clinicians to use the approaches used by the accounting principles. That's on, but I do think that there is a way that you can actually get around it by looking at length of stay, looking at costs in your lab, your pharmacy, your OR, and there are ways to do it, but it's just a chore to make that happen. And if you think that that's your shortcut to making it happen, that will add that over time. That will far outweigh the costs of implementing a case costing system. Just related to the quality piece, just quickly, we've spent a fair bit of time going beyond the case costing and building a data warehouse for our hospital in which we have our patient registration data, we have our hospital information systems from electronic health record perspective, we have our DAD, our NACRs, we have our general ledger information. We even have our patient experience survey results. And so actually we're linking all of this together. So now we can really quite nicely explain, some of the variation may be driven by complications. Some of the variation may be driven by long length of stay that's caused by physician factors or provider factors. And so tying, and then also we can see the patient experience scores and how they relate to some of these other things, which is actually probably the sort of where you want to get. You can tell everything about the patient from a cost and quality perspective together.
That's great. I'm afraid that I've got the time is up sign in front of us here. Obviously, I think we could probably go for another hour with this group. I really just want to say a big thank you to everyone. I think, people are very engaged around this topic. Thank you for coming to the session. We hope as well that we've been able to emphasize that this is about quality and really a lot of commitment at many levels to look at how we can better support adoption and introduction of the kind of clinical care that we hope to provide to our patients. I also just want to say a quick thanks to our team of Suda, Brittany, and Diana up here who really helped to bring this whole panel together today. So thank you very much for that. And then finally, I just want to just remind everybody to please make your way out of the room now because we are going to have to set up for another session and you need to get somewhere else too. Thanks very much. Thanks very much, everyone.